This is an orthokeratology case where the patient's not getting very much treatment after wearing lenses. Looking at the baseline topographies, a couple of things I'd recommend, or the one thing I'd recommend, is to edit out these areas of steepening that are, I think, artifacts. If we bring up the lenses, we can see, especially in the right eye, where Wave has brought that into the topography upon which the lens is being constructed. And I don't think this is really the shape of the cornea here. We're going to get an area where Wave is going to make the lens really dive into the cornea, and we may not want that. So in designing lenses, I do recommend editing out these artifactual areas of steepening or flattening, whatever the case may be. It does help to give us more predictable lenses. So here are the lenses for the patient's right and left eyes, and the patient is getting almost zero treatment after lens wear. So it's a fairly complex lens. We've got the freeform lens, blending is turned off, we got some shape factor. I think we just need to scale that back a little bit. Pretty standard prescription, and I think we can do a more conventional Ortho-K design. In the left eye, we want the smaller OZ in hopes of better myopia control. That's definitely a good target, but we probably don't have to go quite that small. Remember, with Ortho-K, we get central flattening, peripheral steepening, but the central zone is not going to be very uniform, even refractively. So the patient may get 3 diopters of correction of myopia centrally, but it will slowly and gradually fade out. So if we have a very, very small pupil, or not anatomical pupils, but if we have a very small optic zone, there's just not enough room for that treatment to phase out and provide enough correction for the patient's refractive error. So I usually go with a 5/6 OZ, and if I'm especially concerned about progression, we can drop that down to maybe a 5/2, but I usually don't go much smaller than that, and it seems to work pretty well for most patients. So in the right eye, we have a slightly larger zone. I think we're 5/8 and 6/4. Also, when I caliper this cornea, we're getting pretty close to an 11.5 or 11.6 diameter, and so we can go a fair amount larger with the lenses that we have. So for the right eye, I'm going to go up to an 11.2. We're going to, why don't we go with a 5/2. And then a 5/8. That should give us a small treatment zone. It'll have, I think, a fair amount of plus inside the pupil, but also correct the patient's refractive error. I'm going to turn the blending back on. We can leave it in free form, but we'll set the shape factor back to 0. Okay, this lens needs a little bit more topo demand for a -275 cornea. About a 1.4, I think, is going to be pretty reasonable. Okay, so I'm just going to check the individual meridians, and we can even this out a little bit. Okay, so now we're pretty uniform at a 1.4 pretty much all the way around. Looks like we have a fair amount of central clearance, so we can decrease that a little bit. It's okay to have some wave lenses, I feel like, don't seal off really tightly in the periphery, so it's fine to leave some central clearance there. That way we can we ensure that we're getting good seal off at the back edge of the optic zone. All right, so it's a little bit larger lens. Remove some of the um, extra modifications, and I think this lens should fit pretty well and get your patient seeing closer to 20/20. You can use the duplicate the design for the left eye in terms of process. There's no shape factor in the left eye, but we can turn the blending back on. In this eye, we're in GSIM, and then go ahead and adjust the diameter of the IC. And again, at about a -3 or -3 1/4, we can use a power of about 1.4. So hopefully that's helpful. Best of luck with this patient, and thanks for watching.